Now coming to certain parts about the abdominal closure, the anatomy and the abdominal closure. Now, the facts that you should know. Number one, healing wound never regains its total extent. Never. 100%, never. The best, 70 to 80% at 12 weeks. That's the best you can hope for. Number one. Number two, the normal force at the abdominal wall is 16 Newton per centimeter. Maximum force at the abdominal wall is 27 Newton per centimeter. Right? Now, that is basically the extent. Okay. Now, the force which is applied the abdomen. The maximum force is applied when? When you're coughing, when you're sneezing, when you're exerting for defecation, when you're exerting for urination, in those conditions. So that is when you have a rise in the abdominal pressure, right? Okay. Now, the recommendations of European Hernia Society 2015, these recommendations should be known. Why? Because the recommendation, these are recommendations which are in place since 250, right? And what are they concerned with? Number one, this is basically help you to decrease the incidence of ventral hernia. That's after all, when you're doing a stitching back of the abdomen, what do you basically want? There should be no complications. One of the very important complications, troublesome complication, is what is basically ventral hernia. You don't want that to happen, right? So to decrease the incidence of ventral hernia, number one, utilize a non-midline approach to laparotomy. That means paramedian incision. Now, easier said than done. Why? Because giving a paramedian incision is very, very troublesome. It's time consuming. Number two, it gives you less exposure, and extending this incision is again very, very difficult. And that's why, despite the fact that everybody knows that a midline incision is slightly inferior to the paramedian incision, we still prefer the midline incision. Okay, we still prefer that. Right? Now, to decrease, so number one, non-midline should be preferred. For elective midline incision, because I said earlier, we still prefer the midline. So if at all you're giving elective midline incision, number one, when you stitch it back, utilize a very slow absorbable or non-absorbable monofilament suture. Remember that. All the three words are important. Absorbable, slow absorbable, and monofilament. Why would I not suggest non-absorbable? Because a non-absorbable suture all gives rise to postoperative problem in the form of sinuses. The patient keeps on feeling that particular area and is very troubled by that, the cut ends of the suture. So what is better? The better is giving a slow absorbable. Now, just before that, I'd like to have this disclosure that we have not been able to take into due permission for copyright purposes, and because of COVID lockdown, and otherwise the lectures purely for educational purposes, a non-profit kind of thing. And then we have used main reference books like Sutures and the Surgical in North America. So we are not going to take the copyright, right? Now let's talk about the abdominal closure. The fact that you need to know before you go ahead with the abdominal closure. Number one, the healing wound regains its strength 20% the original at 3 weeks. That's the time when you are cutting a skin suture. Remember, you're cutting sutures of 8, 10 days, 12 days. And that means the wound strength is not even 20%. At 12 weeks, it goes to 70 to 80%. Agree. But it never regains its original 100% strength. And that's a very important fact which has to be kept in mind when you're switching the abdomen. And the forces on the abdominal wall are all there, right? The normal force on the abdominal wall in normal activities in the region of 16 to 16 newtons per centimeter, with almost about 150 millimeters of mercury. And the maximum force on the abdominal wall in your violent expulsive events or vomiting, coughing, or you have severe constipation go right up to 27 newtons per centimeter, right? And a recent study evaluating the surgery residents found that only 10% of the residents knew the correct suture to wound length ratio. 10%, imagine that. And 40% are familiar with the literature on the proper technique of abdominal closure, right? Now, if you look at the European Hernia Society guidelines on the closure of abdominal wall incisions 2015, they say to decrease the incidence of incisional hernias, it is strongly recommended that you should use a non-midline approach to a laparotomy whenever possible, right? And for elective midline incision, it's strongly recommended that you use a slowly absorbable or non-absorbable monofilament best period. Now let's come to the first one first. Non-midline approach has been recommended, but what do we find? We find that most of the time we try or we prefer giving a midline incision, and we have reasons for that. The reason is that it can easily be extended up and down to give more exposure. While you try extending a non-midline or paramedian incision up and down, creates a lot of problems. It's very messy, a lot of bleeding, and the muscle also gets damaged because you are retracting the whole muscle to what extent you're giving the incision. And I said earlier in the earlier slides, we already talked about that if you retract the rectus abdominis too far laterally, you're able to, or you're liable to damage the vascular supply, which is lying at the posterior lateral border of the muscle, underneath the muscle and in front of the posterior rectus sheath. You know, I talked about that. And if you do a muscle splitting approach, then whatever is lying medially, whatever you split and left behind medially, is already, or it is destined to get atrophy. So that is lost. So basically, you have to remember that a non-midline approach, despite the fact that it gives you less incidence of hernia, it's not a very easy incident in the sense it's very cumbersome, right? Not very difficult, but it's very cumbersome. The elective midline incision, it is strongly recommended that you use a slowly absorbable or monofilament, not the monofilament suture. Now, problem with the monofilament suture is that initially, when prolines or polypropylene or proline was used for the first time in the nylon suture, it was in vogue and everything was used, they used to close everything with the monofilament suture proline. That was the time when midline incisions used to burst open, and there were a lot of incisional hernias in the earlier days, right? So they picked up proline and they gobbled it up and they used everywhere. The problem with the suture was that the knot, it always lies subcutaneously and is a great irritant both for the patient, and then it becomes an irritant for the surgeon, because every time the patient keeps coming back to you that, look, I feel this, or it may burst, or it may come out through the skin by causing pressure necrosis, and then you have to remove it. So that is why a better suture would be something which gets absorbed. But you don't want a suture which is absorbed before the time that the wound has been able to get enough strength. Which wound are we talking about? We're talking about the linea alba, because that's where you're going to apply this. Now, linea alba, as I said earlier just now, we said that the 80%, 70-80% strength is only there after 12 weeks. So that means basically you would like a suture which should be there at least for 2 to 3 months, at least 12 weeks. So basically, you're looking at what? You're looking at any kind of a suture which should be there for a long period of time. Vital suture fits the bill, no doubt, but then again, it does not have the extent of being there until the whole or adequate amount of healing is there. And that is why the suture to be used is a polydiaphnone or PDS suture, which retains 70% of its initial tensile strength at 2 weeks, 50 at 4 weeks, and 25 at 6 weeks. So basically, it's a suture which is giving you an adequate amount of tensile strength as compared to vital, which is basically glycolic acid or polygalactic acid. Vital is polygalactic acid. So basically, these sutures do not give you that kind of a tensile strength. Why? Because with passage time, they weaken, right? And that is why the PDS is the best suture to close the abdomen with. It is essentially absorbed once 80 days. That's one. Number two, a single layer eponeurotic closure technique without separate closure of the peritoneum has been recommended. We all know why. Because peritoneal stitching leads to a lot of adhesion formation. And that has now been clearly cited that peritoneal stitching is, of course, for adhesive intestinal or appearance of adhesions. It can always lead to adhesive intestinal obstruction. So leave the peritoneum behind, a single layer eponeurotic, leave the peritoneum behind. It should be continuous suturing technique, and there should be small bites of 5 to 8 millimeters from the margin and 5 millimeter apart technique. The initial recommendation was 1 centimeter and 1 centimeter, basically meaning 1 centimeter from the margin and 1 centimeter in between two sutures. But now this recommended is 5 to 8 millimeters from the margin and 5 millimeter apart. That's good enough, because if you do this, then your suture length would be 4:1. And that is what is required with a suture to wound length of 4:1. So if you're giving this kind of a suture, applying this kind of a suture, you'll be utilizing 4:1 ratio of the suture length, right? And then use self-locking anchor knot or Aberdeen knot at the end. Now, remember, whenever you tie a knot in the suture, you apply some kind of a pressure, and that pressure or the pulling apart of the suture, it always weakens the suture, right? Now, when you use an Aberdeen knot, you're weakening the suture only by 5 to 10% as compared to weakening by 40% with the conventional knot. That means when you're tying the suture at the end of your suture, you would be weakening the suture at that particular point by 40%. And that can easily break out and you can have a instilled hernia. Instead, use an Aberdeen knot or an anchor knot, and that will give you a 5 to 10% weakening of the knot only, right? Now, for emergency midline laparotomy, there are currently no recommendations as far as the EH is concerned on the optimal technique of closure, right? The other recommendation comes in the form of a prophylactic mesh augmentation, and they say it appears to be effective. Now, the word prophylactic mesh augmentation is important. To understand this, what we're basically looking at is when you're closing the abdomen, for whatever reason you've done a laparotomy, you're closing the abdomen and you fear that this patient will be having an increased chance of internal hernia. So what do? You put in the mesh even before the internal hernia appears. So that is basically prophylactic mesh augmentation. Now it appears to be effective and safe and can be suggested in high-risk clean patients. That's basically CDC type 1 wounds. With, like example, you're doing aortic aneurysm surgery or you've been operating on an obese patient. Now for laparoscopic surgery, it is suggested that you should use the smallest trocar size. That basically means 5 millimeter trocars. They never give rise to internal hernias, as opposed to a 10 millimeter trocar or above that, they can always give rise to internal hernias. So 10 millimeter and above, internal hernias. 5 millimeter below, no internal hernias. So 3 millimeter port, a 5 millimeter port doesn't give rise to any internal. And for a single incision laparoscopic surgery, what is advised is that you should close the layers very, very carefully to avoid the increased risk for internal hernia, for which it is always blamed. A single incision laparoscopic hernia is blamed maximally for the high incidence of internal hernia in these patients, right? Now, that is why the guidelines, we just talked about that the midline incision, if you have a 4:1, less than 4:1 ratio, you have a hernia rate of 24%, almost. While if you're using an adequate length of 4:1, you have only hernia rate of 9%. Paramedian incision, they are independent of the SLWL ratio, that is a suture length, wound length ratio. You can use whatever length you want, but it doesn't give rise to any increased incidence of hernia. Why? Because you got the rectus abdominis to buttress both the layers. You're also closing rectus abdominis in 2 layers, the posterior sheath and anterior sheath, and in between you got the rectus abdominis. So there's hardly a chance for a incident hernia. So EHS guidelines 215 continued. The incision side, they say reduced incisional hernia rates are seen when lateral paramedian and unilateral transverse. 2.5, 10.5, right? Phalansteal incision, again a good incision. Laparoscopic surgery, good. But if you have higher rates of incisional hernia, you can see them when all vertical incisions versus transverse incisions, especially midline, 10.5%. Infraumbilical midline is the most notorious, gives rise to the maximum number of incisional hernias for the reason you always know, or you already know, that below the arcuate line, there's hardly any posterior sheath. It has got a thin, flimsy layer of transverse fascia, so the highest chances of incisional hernia. You only got one anterior sheath. That's all. You don't have anything else. Bilateral unilateral subcostal incisions, because the external incision, yes. And of course, flank incisions are also notorious for increased incidence of incisional hernia. Now, if you look at the closure, there's some commandments or basically some suggestions. So, number one, you have to be thorough with the basics in fascia healing, right? You should understand the anatomy. You should understand the physiology of the abdominal wall, what we've been talking about in the last lecture. You should make the right incision, select it, and then use the right technique for making an incision, right? The technique basically has to be fast, easy, cost-effective, not to the extent that you butcher everything up. No, not that far. But it has to be a meticulous surgery. A meticulous surgery should be easy, cost-effective, right? And should be such that it is associated with minimal early or late complications. As I said earlier, you need not or you should not close the peritoneum. Mass closure based on Jenkins rule, just over which Jenkins rule is, should be advocated. And one should use the right suture, the suturing technique and good knotting technique. We already referred to that. We should use PDS suture in a midline. Suturing technique, we already said 5 into 5, that means 5 millimeter, 5 millimeter, or 8 millimeters. and good knocking technique, we already said the Aberdeen and not at the end of the suture, right? And what is most important is that you should not always try to close the abdomen, not like trussing something up. You try to push everything in the back and try to close the zip, and what happens? The zip pops out. Similarly, in the abdomen, you try to push the intestine inside, and you try to close the abdomen. What do you find? The sutures cut through. They cut through. So please do not try to truss the intestines inside and try to close the abdomen, what is known as stuffing a living turkey. Don't try to do it, right? And you should desist from using what were being used earlier, what were known as tension band sutures. They were in vogue about 15-20 years back. In any kind of emergency surgery, when they found them not easily closable, they use these tension band sutures, right? Now, the not always try to close the abdomen and difficult closure. This is from using tension band sutures. Basically, what is it all about? Now, basically, when you have a distended abdomen, like example, intestinal obstruction, you've done whatever you wanted to, you have released the obstruction, you try to collapse the bowel by trying to emptying it, the bowel doesn't collapse, and the patient, the anesthetist doesn't give you enough time to close the abdomen, so you have to do it hurriedly, and you try to truss everything inside. Now, if you suspect that this patient is going to have an increased abdominal hypertension or abdominal compartment syndrome, please do not try to close the abdomen. Why? Because even a transient IAH or abdominal compartment syndrome, ACS, would lead to physiological changes which may become irreversible. Now, the event was transient. That means the IAH or ACS was transient. But it has led to what? Irreversible physiological change, which become highly morbid or may even be mortal for the patient, right? There's also a risk of producing bowstring damage or cheese cutting effect on the bowel when it's coming in contact with the interprotein segment of these tight sutures. Now, if this is the abdomen, the suture is coming from here. Now, when you tight close it, then this suture is like a bowstring because the two edges out here and the suture is coming from here, so it's like a bowstring underneath. Now, this bowstring would be in contact with what? The intestine. Now, the intestine, suppose this is a bowstring, the intestine peristalsis keeps cutting like this. So, it becomes just like a knife cutting through butter. So, please don't do that. That's got a bowstring damage or cheese cutting effect when you're doing a tension closure with any kind of suture, whether PDA suture or using Pulley or using vacuum, whatever, right? So, the tight intense sutures, in addition, they also cut through the skin. So that is very important. You should look at should not, because the more the tension, the more the traction on the skin edges. So basically, to prevent this extra-abdominal part from cutting through the skin, you use a buttress plastic tube. I'll tell you what this is basically all about. And if you suspect that this patient is going to have an IAH or ACS, then these are better managed. Such abdomens are better managed as open abdomens or laparostomies with or without zipper, right? So basically, the decision regarding closing or leaving the abdomen open shall be based on an objective scoring rather than a gut feeling. You have a gut feeling, look, if I do this, this patient is going to have an ACS. Maybe you're right, maybe you're wrong. But if you have some kind of an objectivity to it, that would be good enough. And the most objective would be the poor Apache 2 scores, right? So you have tried this patient. Preoperatively, you have the baseline parameter of this patient. And peroperatively, something is added to it. You do a complete scoring, you find the Apache 2 score to be a poor score. So in those cases, please do not close the abdomen. You have an edematous bowel, you have a severely distended bowel, and you try to close the abdomen, please do not do it. If the patient has got a traumatic abdomen, a part of the abdominal wall has been lost, please do not try to close it. If there's an intraperitoneal contamination, please do not try to close it. So basically, it is an indication where you would like to go in for a laparostomy rather than leaving the abdomen partially open and doing something about it, or rather than trying to close the abdomen in a hurry. So if you look at the incisions and closure types, we talk about the paramedian versus midline. Now, midline, as I said earlier, excellent exposure, fast, minimal risk of significant vascular or nerve injury, right? Almost comparable rates of hernia and other complication versus transverse incision. So far, so good. But what about comparison paramedian? Now, they score less as far as paramedian is concerned. But the paramedian has got its own drawbacks: time-consuming, limited exposure, immediate complication more than a midline, rectus atrophy, and better if the incision is intraumbilical exploration. Yes, it is good. As far as supraumbilical is concerned, necessarily not. Right? Transverse incisions, they create less tension. If given along the Langer's line, then the scar is good. The scar is better because there's no tension on the scar, right? And that's why the incidence of hernias at Wood has been reported to be the lowest, right? And that's why in 2005, Cochrane review concluded there is no difference in hernias in midline of the transverse incisions, and they were more in midline versus Paramedian. That is the Cochrane review page, right? So innumerable studies as far as midline continuous interrupted is concerned, and the latest that we have is surgery 38. The recommendation is continuous sutures for elective midline laparotomy wounds, bites and distance 5 mm to 5 mm. The Dutch trial, the Switch trial, this was basically trial 2015 recommended the small bites technique should become the standard closure technique for midline incision, right? And the optimal recommendation is pointed out earlier where emergency laparotomy is still awaited, right? This continent basically trial started November 2007 and the study is still on. We don't have the recommendation as far as that's concerned. So midline continues boosted by the spring coil effect theory of Jenkins. Now basically what is this spring coil theory is all about? This basically, it is understanding that if you give a continuous suture, it is working like a spring coil. Now, the spring coil can accommodate some kind of edema and some kind of a pulling apart. So, when you're giving suturing the midline back, you're applying sutures and they should not be too tight. Why? Because they have to accommodate the post-operative edema. The length and width of the wound both increase in the post-operative period. If you get too tight sutures or interval sutures, what's going to happen? They're going to play, the edema is going to give tension on the sutures, going to play against the bite of the suture. And that is why it is said that you just approximate the edges. Just approximate the edges. And if you just approximate the edges, that will basically, that is basically going to be accommodated by the spring coil effect, right? So that is why if you give 0.5 to 0.5 centimeters or 5 to 8 millimeters, 5 to 8 millimeters, that is basically beneficial to accommodate the edema and the length. Without locking and tension, again important continuous bites. Why? Because locking and tension gives you interrupted points where the edema cannot be further accommodated. So this basically spring coil effect would accommodate what? The edema, the 30% increase in the length of the wound in the immediate postoperative period, and it also promotes the healing. How? By promoting type 1 collagen. We all know type 1 collagen is a mature collagen and is maximum 1 centimeter away from the edge of the rectus sheath. Now, early granulation, you have a low 1:3. That means more of collagen 3, less of collagen 1. The mature has more of collagen 1. So, with the passage of time, the late granulation, it becomes more strengthified by what? It gets more strength by conversion to collagen 1. And pliable tissue, we already said that the ratio 1:3:1, and basically the collagen 1 is going to increase. Disadvantage of continuous suturing, is there one disadvantage? Yes, if the knot opens up, everything is popping out. But if you have a complete disruption, it is a very rare occurrence. It's a rarity, right? Extremely rare cause. The potential disadvantage can be overcome if a self-locking knot or a abdominal shoemaker knot is employed instead of a traditional. I told you traditional knot is going to give rise to weakness of 40%, loss of strength. Abdominal shoemaker knot gives a decrease or loss of only 5 to 10%. So that is better. It will not weaken your suture. Then the self-locking knots are smaller, less likely to slip than conventional knots. So we don't usually use them. And they reduce the suture length by only 5-10% compared to the reduction of 40% reduction by traditional knots. So basically, the self-locking knots are easier, smaller, less likely to slip, and weakness 5 to 10%. That one of the best self-locking knot is the abdominal knot. So use the abdominal knot. The other thing important is we always tend to use very sharp needles and large needles. Makes the suturing very easy. But when you suture with a large needle, imagine a thick large needle, the suture that is carrying is not equal to the diameter to the needle. So what happens? The needle point creates a defect in the fascia which is not totally occupied by the suture coming behind it. So that means the suture is a loose fit in that opening made by the needle. So what's going to happen? What can happen is what is known as the needle tract hernia, needle hole hernia. And that's why next time you try to suture a fascia, please try to stitch it with a medium and round bodied or not a very sharp needle. So don't use very large needles. Use smaller needles, and where the needle diameter and the diameter of a suture is almost. So because when you're tightening it, then it's also going to tear. So that needle track is going to become larger if you're using a very large needle, right? And you had this midline versus the prophylactic mesh you all talked about. This trial has started 2019, still under the still working. They're still working on the trial. They're analyzing patients, and basically it should be a logical, innovative step putting in a mesh. But I really don't know how that's true. But if it's a CDC type 1 wound, you can afford to put it in. But there are complications. Mesh is not without complications. So until we have the level 1 evidence from the study, we do not know how it's going to turn out. Now, this is basically continuous with double loop suture. So this is the double loop. See this double loop? Now, this double loop is being taken and the needle is taken from the loop. So you don't need to apply any kind of knotting here. Point number 1. So no weakening out here, right? 2 knots to a suture, one here and the other lower down. So the both of them. So this is at given up, right? Because you don't need to tie a knot out here, and you keep taking the needle out. And once you come to the end, you draw this out and you cut one of them. So one length comes here, one length comes here, and then you tie. So this is basically the double loop suture. That's how you do, and this would at least reduce 1 knot from your suture. Alternatively, you can use interrupted sutures, interrupted simple, vertical, horizontal mattress, interrupted figure of 8 suture. I'll just tell you what this figure of 8 suture is. Far, near, far, what is known as a remodified Smith Jones or pulley stitch, or a tandem pulley stitch is a pulley stitch and horizontal mattress or a suture, right? So these are some of the sutures. I'll just tell you what these sutures are. So this is basically interrupted figure of 8. You can easily be seen how you take the suture. So this is outside in, inside out, and then at a distance, outside in, inside out. And when you tie them, it becomes a figure of 8. And remember, the knot should never be over the suture line. It should be on one side of the suture line, right? So this is basically non-absorbable, or you can use as a PDS, and it should be such. When you tie the knot, one more thing you have to remember is that the finger should go in between the suture thread and the wall. That gives you enough tightness. If you tighten further, there's going to give rise to ischemia. So it should be such that it's going to be tightened over your finger, and the finger can easily be introduced inside. This is basically a pulley stitch, and you look at the pulley stitch. This is basically at a distance. It is coming from outside in, taking all the layers. See, this is important. Taking all the layers, and to the opposite side, it's taking only part of the layer. It's going through the wall. It's not taking the whole inclusive wall. Through the wall and from inside out. And then this is towards the margin. And then you take another bite from the margin. So this is basically again outside in. Now this is coming through a part of the wall, not the whole wall. And then it exits the whole wall and takes the far side. So this is basically outside in, inside out, outside in, inside out. This is basically the pulley suture, also known as the pulley suture. That's how it will look when it's tied, and see the knot is again distant from the far line. Now, this is basically the far, near, far. We talked about that. This is also known as the remodified Smith Jones retention suture. And this I just showed you how it's basically done. Now, this is basically slightly different from the one that we just now showed, the pulley suture. Now, the pulley suture, right? Now, what is different? If you look at the suture, basically this is forming a loop out here. Now, it's forming a loop out here. This is a small intraperoneal loop. Now, if you look at the last one, you see this part is intraperoneal, this part is intraperoneal. Quite a length. If you look out here, it is a very, very small part which is intraperoneal. So that cheese cutting effect is not there. The cheese cutting effect is not there. Why? Because this would be such that it's becoming closely opposed to the wall. Suppose if you took a suture from here and you took it out here and tightened out here. Now this whole length, now the suture would have been there, giving rise to a cheese effect or a cutting cheese effect, right? So that basically these sutures basically such the modified that it would give rise to a small interperoneal loop. So there is no chance of a loop being entrapped inside the loop, or there is no chance of the cheese cutting effect, right? So this is basically a thing which is to be kept in mind. Number two, that this part should not be such that it's going to include the rectus lateral wall. Right? Why? Because remember I told you that if the whole length of rectus, the whole width of rectus is included in between, what's going to happen? The posterior lateral vessel lying out here would be entrapped out here. So if this is the rectus abdominis and this is lateral of the rectus abdominis, you've taken a suture at the lateral or the semilunar line, right? In your wisdom that I would have a further grip, a better grip, I took if this is the rectus abdominis, I took a bite just lying lateral to the rectus and here lateral rectus. What is lying out here? If it is sheath, the vessel is here. So when you tighten it, what's going to happen? You're damaging the supply to the rectus abdominis, leading to what? Leading to the damaging which blood supply? The superior epigastric and the inferior epigastric. I showed you in the early surgical anatomy. So losing what in that effect? Atrophy of the rectus abdominis. Why atrophy? Because now there is no supply to the rectus abdominis. So it undergoes atrophy. So remember, it should be within 3 to 5 centimeters from the cut edge. It should not be further laterally. Why? Because there it would be giving rise to ischemia of the rectus abdominis. Right? Now, this basically modified Gambee suture is much better. Gives rise to less of intraperitoneal. Why? This prevents the cheese cutter effect the most effectively. Because we see out here what's happening. Part of the wall just leaving the skin, this subcutaneous tissue comes out here and it is continuous to the wall, just in closer position, the intraperitoneal part, and it comes out here and brings out here. So when you tighten it, this part is never going to give rise to a bowstring effect. Never bowstring effect. It's always opposed to the parietal peritoneum. So this is basically the cheese cutter effect is not there in this modified Gambee space. There's just something which always it's also used for doing external anastomosis. This is basically a huge abdominal repair of the heart and the abdominal wall closure technique. This is a very, very complex suture, still under study, is still under evaluation, and I don't know how far this is going to be taken up. It's a very, very complex suture, at least I don't like it, and it's not been accepted in textbooks, it's still under trial, right? Now, what happens in difficult closures? Retention sutures, temporary abdominal closures, this is supposed the preferred method, what we know as laparostomies, but retention sutures also there. I'll just give you an idea what these were. So you're not able to close the abdomen, you've got two options with you. Close with difficulty, you've got two options. One, use retention sutures, try to drag everything. But if you feel that the patient is going to have ACS, then you're going for temporary abdominal closure, which should be the preferred method. But just a word about retention sutures or tension sutures all about. We said the guidelines say that they should not be used. There should no positive effect in the use of prophylactic retention sutures. There are two scenarios. One, you have an elective surgery done and you suspect that this patient is going to have a cut through later on. Like example, in a patient who's severely malnourished, or a patient who's immunocompromised, or a patient who's got a previous special defect, and you're doing an elective surgery and you suspect that this patient will be having still hernia later on, or it will break open even in the immediate postoperative period. So there you give a prophylactic retention suture that may be given, but as a aid in the descended abdomen, it should never be given, right? So in the emergency situation, it has got a lot of problems. In prophylactic, it may have less problems, but still it has problems, right? But they may be useful in this scenario, okay? Right. So basically, they are placed outside the primary suture line. So you've got a suture line like this. You apply sutures out here, and lateral to these sutures, you add another row of sutures. So these are lying lateral to all layers of the abdominal wall, including the skin. A large bow suture material using non-absorbable is usually employed, right? That's usually employed. And the effect is what? To alleviate the tension of the primary suture line. So if you look at the figure out here, let me show you this. I'll show you a figure later on. So basically, you're reducing the tension on the primary suture line by applying the sutures outside the suture line as a secondary, right? So these are basically incorporating large portion of tissue tied under tension. So basically, try something on tension and possibly then you lead to what? You lead to a lot of necrosis, a lot of ischemia. And to close, because you can always cause skin ischemia and skin tearing. So you have to close the sutures over what? Some kind of a bolster, suture guard, bumps, or bridges, whatever. And it should be removed as soon as the danger of increased tension has gone. See what he said? These are sutures as a second row. So this is a primary suture line, and these are lying lateral to the suture line, right? Lateral. So this is going to reduce all kind of tension on this suture line. This is how it looks like. The primary suture line and these sutures out here. And the bolsters or the protectors are these. This is the tubing. It may be rubber tubing or polythene tubing. So this protects the skin from the excessive cut through of the skin by this tight suture. So this basically is a tight suture. See, it is indenting. See the edema. It's indenting the whole thing. So if you don't apply this this bolster or this tubing, what's going to happen? It's going to cut through the skin like it's going to slice. It's going to slice. So that is why this is required. These guards are required. So you can apply either plain interrupted, this is plain interrupted, or you can apply what? A horizontal mattress or remodified seat zone sutures, which is not comfortable, right? So the problems and complications are all there. It exacerbates the abdominal compartment syndrome. I just not told you. It may be transient or it may be a permanent ACS, right? It precipitates rectal muscle atrophy. I told you how it does that. So that muscle atrophy is by constriction of the epigastric vessels, the interior of the superior, whatever. Flap necrosis. Why? Because the skin is undergoing necrosis. Great amount of postoperative pain. Now, instead of one row of sutures, the patient got 2 rows of sutures. Obviously, the pain has to be more. And it's been implicated in the development of anterior fistulas, even when the sutures are placed extraperitoneally. Intraperitoneal, we all know the bowstring effect, going to cut through the bowel. But even when they're placed extraperitoneally, the chance of having a fistula is always there. If you look at the Pascal's law, how is it applied to the abdomen? That's important. And the law has got a number of important implications in abdominal surgery, especially abdominal compartment syndrome. So now we are basically talking about physics to abdomen, right? The abdominal wall and the diaphragm, they represent a anterior superior surface or closed container. So it's like a tube, right? The whole abdomen is like a tube. Upper you got diaphragm, below you got the pelvic diaphragm, and you got the abdominal wall. So pelvic diaphragm, abdominal wall like a round. So you got a cylinder, right? So if you got an increase in pressure in a cylinder, what's going to happen? It's going to reflect on all sides. So equal pressure on the diaphragm, the pelvic diaphragm, the abdominal wall on all sides. Posteriorly is taken care by what? The bony structure. So you got bony structure there. So whatever pressure is going to act on the structures lying against that bony structure would be pressing those structures. Why? Because the bony structure is not going to accommodate any pressure. Abdominal wall pressure applied, what happens? Abdominal wall distends. So this part is going to distend. But this part is going to, so if this abdomen is going to distend more. But if the intestine or the vessels are lying against the bony structure, that pressure is only going to press those structures against the bony structure. Like, for example, the vascular compartment, or the IVC and the aorta is going to be pressed. Why? Because this is a non-compliant. If it was compliant, it would have gone like this, so the pressure would not be there. So basically what's going to happen? Organ dysfunction caused by intra-abdominal hypertension. Which organ dysfunction? The renal, a secondary cardiovascular, respiratory. So these are some of the systems involved by virtue of compression of the IVC and the upward push on the diaphragm. And it usually goes unnoticed. Why? Unrecognized in a serious patient. Why? That patient's already got some kind of a compromise of the kidney system. He's got a compromise of the respiratory system. So this ACS rise is not going to be recognized early. If it has been an elective patient, you recognize, yes, this patient had a normal immune function. Now see what's happened. He's got normal respiration, see what's happened. But the patient who's in emergency, has been operated emergency, he already had pre-existing organ dysfunction. They recognizing ACS becomes very difficult, and recognizing it early is very important. But in that patient, it becomes very difficult to recognize that. So what you can do at least is, please do not try to give this patient a ACS, right? So basically it's perplexing for surgeons whether a patient developing ACS was only relieved by opening the abdomen to the exterior, as to whether that should be done. Now, when he had this Pascal's law, that basically extrapolated that now, yes, we can do that. If you leave the abdomen open, at least that increase in tension can easily accommodate to the most compliant route, and that will be open abdomen. So it is being exerted to the diaphragm, to the lower part of the diaphragm, and the structure lying out there, abdominal wall. Now, bladder is there. So basically, that is going to be given to the pressure is going to be applied to the urinary bladder also. Now, if you can measure, you want to measure the intra-abdominal pressure, which ultimately will give rise to ACS, you can basically do it indirectly by measuring the pressure inside the bladder. And that is exactly done. So, the measurement of intravesical pressure through Pulley's catheter a relatively simple adjunct to clinical monitoring of the patient and enables the early detection of the onset of ACS, right? Alternatively, if you do not do that, you can also use an intragastric IVC measurement or an intracolonic pressure, right? So all of these will give rise to indirect measurement of the pressure of the abdominal pressure, right? If the intravesical pressure increases beyond, so you've done a measurement of the intravesical, if it increases beyond 15 millimeters of mercury, the ACS is impending. Yes, impending, right? So the moment the pressure inside the vesical compartment or the intravesical pressure goes beyond 50 millimeters, see if this patient has got impending ACS, stop the closed abdomen or take whatever remedial measures you have to do in a already closed abdomen, right? So whatever you have to do, reduce the pressure. Why? Because intracaval compression will give rise to decreased cardiac return, decreased cardiac output, and the whole chain is set up, the dam pushed up, and it sets a chain of all kinds of respiratory problems and ARDS ultimately. So how do you do it? Indwelling Pulley's catheter, just instill 70 ml saline into the bladder, clamp it, then put an 18 gauge needle with aspiration port, connect to a transducer. The zero of this transducer should be at the mid-axillary line, because that's the heart level. Measure pressure at the end expiration. So points important: 70 ml saline, 18 gauge needle, transducer zero on the mid-axillary line, and end expiratory pressure. This gives you the indirect IAP. Gives it indirect intra-abdominal pressure IAP. If you have intra-abdominal hypertension, basically you would say that when you have IAP more than 12 millimeters of mercury, and we would call it ACS if the pressure or the IAP is beyond 20 millimeters of mercury, but that's not the full part of the definition. It should always be having new organ dysfunction. So the complete definition of ACS would be internal pressure of 20 millimeters of mercury and a new organ dysfunction. Apart from possibly after retention sutures, that's one of the major reasons, or you can also have other reasons, but here basically we consider the retention sutures. So retention suture can always give rise to this whole scenario. Apart from retention suture, it can also be seen with other clinical presentation, like for example, a penetrating abdominal trauma, intraabdominal hemorrhages. Pancreatitis is a very glaring example. Post-operative state, large volume resuscitation. This patient has come to you, he was very sick and he was severely dehydrated. In your wisdom, you keep pumping fluid. And you found elevation of the blood pressure, very happy. You wanted to push more fluid. Now what do you find? You suddenly find this patient goes into respiratory embarrassment, this patient goes into hypertension, and you don't understand why that's happening. What has happened? What happened is that you pumped so much fluid inside this patient, the whole of the abdomen has distended, and you've given a patient an increased IAP, and the earlier rise or the restoration of your cardiovascular compartment has now gone into a IAP and ACS. Internal sepsis in another glaring example, and a number of other conditions. So the bottom line is what? Retention sutures have fallen out of favor and are rarely used or should not be used in current general